the first and foremost thing about high blood pressure, whether it's moderately uncontrolled or at a resistant stroke level type of value, is that it's all circulation based. Anywhere you've got arteries, you've got potential risk from high blood pressure. The chief target organs are the brain, the heart, the kidneys, and to a lesser extent, the peripheral circulation in your legs. And what makes high blood pressure so bad is not only does it cause damage when it's not well controlled, and we have ways to measure it and lots of ways to control it, when you have other disorders, call them comorbidities, like diabetes or chronic kidney disease in the first place, it's like throwing gasoline on the fire. It just makes everything far worse. So we say that the effects of risk factors aren't so that, if you have a risk factor of 10 from high blood pressure and a risk factor of 10 from diabetes, when you put them together, maybe it's 12 when you have both. No, it's more like 20 when you have both. So the risk factors are kind of additive. We used to say synergistic. I never liked that because I never believed it and still don't, but I know they're at least additive. The last part of your question was, is it underappreciated? And the answer is, if you believe our data on how many people we have in our adult population, in the US, for example, whose blood pressure is currently diagnosed and managed to current AHA, ACC guidelines, I would say that, the lawyers have a phrase, res ipsa loquitur, the thing speaks for itself. The data shows that more than 40%, if you want the scare tactics than the Stephen King approach, it's more than 70% of our adults are not below 130, which our deities in the ACC and AHA say they should be at this time. There's one huge limitation to current antihypertensive medications. It's called adherence. So what I mean by that, and it's one of the, I guess, every family has its like skeletons in the closet. Well, in the hypertension family, the skeleton we don't like to trot out and acknowledge is the fact that many of our patients, and it's really hard to get an exact number, it's like asking somebody how many drinks they have in a week, how many of our patients don't take all of their medication. They may take some of it. We call that partial adherence. Or they may come and see you. You think you're prescribing 4 drugs for their blood pressure. But if you check their urine and blood to see if you can detect the drugs, 1 person in 6 who tells you, hey, listen, I'm getting all that stuff filled at the pharmacy and taking it faithfully. 1 person in 6. And these are people that are there for their appointment. They're in a hypertension clinic and their blood pressure is outrageous. They are taking nothing that we can detect in the urine or blood. So 40%, some say as high as 50% of our patients are not taking all. They're missing at least one of their pills on a frequent enough basis that we can find it when we look. And final point about this is that when we do clinical trials in hypertension and we tell people, look, you're coming in next Tuesday to get your blood pressure monitor placed on to see how you're doing on this intervention, whatever it is. We're going to check your urine and blood to make sure that Tuesday of next week you took your pills so that when you come in Wednesday, we're good to go and can give you your meds on site. When we tell them about that, and we've done this, and they're in a clinic, they're what's the word, responsible enough to be in a clinical trial where they know they're going to be watched and there's a placebo or a sham control or something like that involved. 40% of them don't take their pills, at least 1 fewer than they're supposed to. And if you do that, look at that, if you assess that 3 times, 0, mid, and end study, it's 40% each time. And it's not the same 40%. There's incest. They go from adherent, partially adherent to adherent, or non-adherent, partially adherent, non-adherent. So there's a bunch of movement back and forth. So it's far worse than just the 2 out of 5 that don't take things correctly. Even amongst our pat them on the back and, give an amen brother to the 3 out of 5 who do, even within them, there's occasional slip-ups as well. So in my mind, that is one of the biggest challenges we face. We have over 120 separate drugs we can use for high blood pressure. They're different. And they're in 5, 6, 7, 8 classes, depending on whether you're a lumper or a splitter. There's lots of things to choose from. The problem is getting people to take them daily because we can't cure high blood pressure in most cases, but we can manage it. The problem is management is a daily issue. And so, it's a challenge to get people to swallow that, especially when they got diabetes and lipid disorders and they maybe have a little trouble inhaling. So they're doing the inhaler, et cetera, maybe taking an oral pill for their asthma or COPD or whatever. Over. There's a couple of things that can be done to enhance adherence. One of my nurse practitioners, Virginia Ford, when she was doing her PhD back in the 90s, she did a study looking at, we're in West Philadelphia. It's it's an urban, but largely minority population in West Philadelphia. And she was curious to know how well people, and this is long before the adherence got to be front page issue the way it is now, how well people took their meds and what were the factors that predicted better adherence. And when she did this survey, she had like 50 of these people from West Philly, almost all were Black American. What she found is that the perceived relationship between the patient and the provider was the single most important factor predicting adherence. And when we have this day and era now where you're giving 12 to 15 minutes for a patient contact in an office setting, and you're spending half your time trying to keep up with the medical record charting so you can hopefully get paid for this visit, that doctor-patient relationship has taken a hit, I think. And part of the issue with adherence is that lack of feeling like this person cares for me and I'm going to make the best effort I can on my part to do what they say because their belief in my health is important to me. And so that, to me, is the most important thing for adherence. Beyond that, we're working on different ways to make taking meds easier. Shots that can be given every 3 or 6 months, interventions that can be one and done, like the innovation and things like that. But that adherence issue is, in my mind, the single greatest challenge we face in this day and age for managing people with high blood pressure. Over.